Now we come to something lighter, but nonetheless clinically very significant and also troubles a lot of patients. In fact, patients with varicose veins form a significant number of cases that I see in my clinic weekly. About half the patients I see come because of some vein problem, be it varicose veins or even deep veins. And it's something that bothers people a lot because it is physically visible. Now, this just shows you the scale of the problem, okay, and where venous reflux disease stands in the scale of disease. So I talked a lot passionately about arterial disease because it affects people's lives, how people lose their legs. We talk about stroke, heart failure, and obviously coronary heart disease is something that dominates every conversation. Everywhere you go, there's something about preserving your heart, doing ballooning. But if you look at the prevalence worldwide, all these diseases combined still equal to the number of cases of venous reflux disease. So it's actually a very significant health problem anywhere in the world. And this is from the US data. Okay. In terms of number of cases in the United States, they diagnose about 30 million cases a year. About 1.9 million seek treatment, and eventually only 500,000 get treated every year in the United States. Similarly, in Singapore, many people walk around with varicose veins but never get treated. And there are a lot of reasons why they don't. Some people are okay with the physical appearance of it. They're not bothered by it. Some people think that it is not life-threatening, so we don't bother to treat it. Some people just don't have time to get treated. Now, in essence, what is varicose veins? Varicose veins basically is a problem with the superficial venous system of your legs. Now, to recap, just now we talked about arteries. Arteries' job is just to bring blood, important, good quality, blood full of nutrients to the legs, to the muscles, to the tissues. The veins, on the other hand, the job is very simple, is to bring blood back to the heart. Okay, so they're totally different from arteries. But understand one thing. If you think about it, 24 hours a day, most of us try and get 8 hours sleep. Some of us get 6 hours sleep. But a large part of your day, you're actually upright, be it seating or walking or standing. So 3/4 of your life, you're upright. Now, when you're upright, there's something called gravity that fights against anything that flows upwards. So in veins, essentially, blood tries to flow up back to your heart to be recirculated, but it's fighting against gravity. And in veins, we are made in a special way. A lot of our veins have got one-way valves inside them. So if you ever operate on the veins, or if you ever see the inside of a vein, you'll find that they have got one-way valves that open in one direction, upwards. But when they close, they prevent blood from pooling down. And we are made that way because of the nature of vein drainage. We are always fighting against gravity. The only time it doesn't really work is when you're lying down, when there's no gravitational force on it. Okay? Now, the other way we are made is also that in our legs, there are two kinds of vein systems, the deep and the superficial. The deep takes care of about 3/4 or 75% of the blood flow back to the heart from your legs. And they are situated inside the muscles of your leg. So that each time you walk, you sit, you contract, you exercise, it squishes on the vein and pushes blood back up. On the other hand, about 25% of the blood flow goes through the superficial system. And this is what it is. And you can see these veins on your legs if you look carefully. You've got this big green one that runs on the inside. Most of us see them on the inside of our foot here. And it travels up in your thigh, and then it goes back to the groin. Okay? This is the major superficial system called the GSV, or the Great Saphenous Vein. It's the longest vein in the body. It travels in the thigh fat and the calf fat. Okay? There are no muscles to squeeze on it because it is in the fat of your thigh and your calf. But they have got valves that prevent backflow down. This is the same vein that a lot of us use when I do bypass surgery. Just now I showed you that picture where there was a big gash in the vein. That's exactly the vein. Many cardiac surgeons use this vein to do heart bypass surgery as well. Okay? Now this is called the superficial Great Saphenous Vein. Okay? So when it goes, it joins in the groin here through an opening with the deep vein. Okay? That's how they all fuse together to bring blood back to the heart. So remember, 75% in the deep vein, 25% in the superficial Great Saphenous Vein. Okay? There's another superficial vein, it's called the short saphenous vein, and that runs at the back of your calf. okay? And it ends somewhere at the knee joint. The location is a bit variable, but it ends at the knee joint. Again, it drains blood from the superficial tissues of your foot back into the deep system and then back into the heart, okay? Remember, the Great Saphenous Vein and the Short Saphenous Vein, 25% of blood flow back only is responsible for that, okay? So this is the Short Saphenous Vein. There's a network of veins here, okay? Now, between the two systems, sometimes you have something called perforators that we see. But what is the problem with the veins I was trying to explain? A normal vein function is exactly like this. Blood goes up, doesn't allow it to come down. The valves work very nicely. And there are many valves in the body. The key big valves are at the groin, where it joins, and the back of the knee. But along the whole tract of the vein, there are many little valves inside. So God, when He invented man, obviously thought of this problem. Because I can't even think of this problem, how to solve this problem. But it's obviously somebody was smarter than us, clearly, right? But what happens when you have varicose veins is the valves fail. Now, why do they fail? What are the risk factors? Okay? This is what it means. Essentially, valve works, valve fails, and then they become dilated over time. So you can see, we're very common to see many people with big varicose veins, with big giant green veins. They all become ballooning over time. Okay? This is what I mean. There are different classes of varicose veins, and we'll talk about risk factors. The earlier stage is when we call it C1, where you have spider reticular veins. These are thread veins. Cosmetically, not very pleasing. A lot of people think it's cosmetic, but some patients actually get aches and heaviness just from this. And you treat this, it goes away. Then it gets a bit more obvious over time. You get these big greenish ones, and these are what we call the big varicose veins. A common complaint also is leg swelling. I see a lot of patients who don't have these, but leg swelling. They just get recurrent leg swelling, and it gets worse. The classic symptom is in the mornings when they wake up, their legs are fine. By the time the end of the day comes, essentially at the end of the day, they find that their legs are very swollen and achy and heavy. They feel as though they have to drag their feet around. Another common complaint, especially among female patients, is that their shoes are very tight shoes, and they can't fit the shoes. Okay? But the moment they sit down and they elevate their legs, it goes away. Okay? Another telltale. A third complaint is cramps. They feel a cramping sensation at the end of the day. Why? Because the muscles are all congested now. The tissue is all congested. Okay? Then if it gets worse, many patients develop eczema. In other words, their skin starts itching. They sometimes peel it. They sometimes scratch it. It becomes discolored. As you can see, it becomes like that. And in very, very severe cases, which we still see a lot now, is the skin breaks down. And this is called a venous ulcer. So what I've shown you is actually a spectrum. It is actually a progression. It starts like this, becomes like this, sometimes mixed with this, and if left untreated, we see this. And I usually see this in the older patients, people who have had varicose veins for 20 years. They start young, and then by the time they hit 50 or 60, then this problem starts developing, and frequently it's innocuous. One patient I had told me he was cycling, he's in his 80s, he's cycling, he cut himself against the pedal of his bike. And then it started with one small bit, and then it just grew bigger and bigger. And now quite a large part of his leg is covered with a big ulcer. All right. Now, what are the risk factors for varicose veins? The most common we see, the most common patients in the patient age group are actually women who have had many children. Okay. Now, why does that happen? We think that with the repeated pregnancies and fetus, it presses exactly on the veins that drain, right? And especially in the pelvis, because remember, the leg veins drain into the pelvic veins that then go up to the heart. Now, we think that maybe with fetus pressing, especially multiple pregnancies, and especially at night when you're sleeping, with added pressure, it basically raises the pressure profile inside the veins and sort of distends the valves repeatedly, such that eventually the valves get stretched open, they never really come together again. So we think that's one risk factor, and it's a known risk factor. The other risk factor, actually, we see a lot of patients who are doing jobs that require a lot of standing. So I see a fair bit of teachers, strangely chefs, people in the retail industry, or they do a lot of sitting, because with your legs dangling down as well, there's a lot of pressure. Okay, so that sort of vocation can predispose you. The third group we see are patients who are a bit heavy set, and it's understandable. So patients who are high BMI, obese, there's a lot of pressure on the body, right, on your legs, and it tends to stretch the veins. Another group that we see are those with a family history. We don't know the genes for it. We haven't identified a particular gene for varicose veins, but we do see family clusters. And I always tell this story that I've got 2 family clusters I look after. One, they have 8 siblings, all 8 of them got varicose veins. 3 of them got ulcers. I've operated on 2 so far. You know, the rest are not deciding operation yet. And then I've got another cluster of 6, I think, siblings, same thing. Okay, and their family history. So if your mom, basically direct first degree, not by marriage obviously, but if your mom, your sister, your father has a history of varicose veins, especially severe, you may be at risk. Why? We don't know, but it's in family clusters. Another group of patients who develop varicose veins are patients who have had blood clotting problems, especially blood clots in the deep venous system, or what you commonly call deep venous thrombosis. Okay, those are, you've heard the stories about the economy class syndrome, patients who fly in tight airplane spaces, then they get clots in their legs. Patients get trauma, they get clots in their legs. They can predispose to development of all these problems later on. Okay, so these are some of the risk factors. Okay, and then of course there's a last group that doesn't have all these risk factors, but they still get varicose veins. We don't know why. Okay. One other common question I get asked is, does wearing high heels cause varicose veins? No evidence to show that. Some people say yes, some people say no, but there have been studies to analyze wearing high heels, and they think it's the fact that with high heels, your pressure in your calf is very high, okay, and it blocks drainage, so to speak, and pulling, but really, nobody really knows what it is. But no, there's no proven evidence that high heels cause that. But the ones that I mentioned are proven. Now, how do we diagnose? I think the most important is, aside from symptomatology. So usually I see a patient, the common presentation of course is big green veins. I've got big ugly green veins that are bulging. I've got veins, sometimes in some patients the veins are very thin out, they first present with bleeding. The veins they scratch the vein and it ruptures and they bleed. And it can bleed significantly. I've had patients who bleed so much they faint. Although it's a venous bleed and not arterial bleed. You never die of it, but you can actually lose consciousness if you don't know what to do, like compress it. I've also got patients who complain about recurrent leg swelling. I've got patients who complain about aching and heavy pain after long periods of standing. So very common. And how we diagnose after that is we use an ultrasound. And this is the gold standard for diagnosis. If you are any doctor that wants to treat varicose veins, you must and should be able to do your own diagnostic ultrasound. Okay, because by only doing the ultrasound yourself, you can diagnose the problem, but you also understand how the vein anatomy is. Okay, I don't know whether you noticed earlier on in this slide, it is important to do the ultrasound because sometimes you may have more than one great saphenous vein. 25% of patients actually have 2 of these veins. And sometimes if you don't do the ultrasound, you miss it, you're treating the wrong vein. Okay? So important to do this. And the first test that we do to diagnose the problem is an ultrasound. There are certain criteria, but in essence, we look at the flow patterns in the veins, and we do it with the patient first sitting or lying down, and then next standing. Obviously, when you're standing, there's a lot more pressure. The symptoms on ultrasound will be picked up easier. Okay? And so we diagnose that. All right? And this is what it means. This is from my old hospital where we just show a diagrammatic representation of what it's like. Essentially an ultrasound machine, and you can see this patient has everything red, which means poor veins, okay, varicose veins, okay. Now, once you diagnose, then the question is, how do you manage? Now, there are 2 basic options, and this is where we discuss with the patients, depending on the patient's lifestyle, risk factors, and so on and so forth. But most conservatively, we manage without surgery. Some patients do not like the idea of surgery. They think that it's a major operation, they need GA, and the most common misconception I hear is that, will I be able to walk? I've got friends who did this operation many years ago and couldn't walk for 2 weeks. The answer is yes, you'll be able to walk with surgery straight after the operation, but there are still patients who prefer not to have operations. In those cases, we talk to them about treating conservatively, which means non-surgically. And what do? We sometimes start medication. There's a tablet that we call Deflon that we give patients to eat. And the idea of Deflon is actually, it is a compound derived from plant extracts or microflavonoids, that what it does is it causes the veins to sort of shrink a little and contract a little. But it never really removes the problem, because if you think about it, this is a physical problem. The problem is the valves are spoiled, the veins are dilated. If you have a physical balloon up, no medicine you're going to take is going to shrink it. Okay, we don't have that tolerability. So only about 50% of patients find an improvement in their symptoms in terms of heaviness, in terms of a little bit of swelling on taking Deflon. But it won't cause the big giant green varicosities to go away. The second thing that we do, which is the cornerstone of conservative non-surgical treatment, is to put patients on stockings. I'm sure you've heard about it. Basically, if the muscles can compress the deep veins, there must be something you can do to compress the superficial veins. And what we do is we make patients wear tight compression stockings. And we advise that you wear them during the day when you're on your feet, at night when you're resting and lying down, or when you're resting at home, your legs elevated, take them off. Okay? But compression stockings in our Singaporean context is a bit difficult. It's a very Western concept, but they have got 4 seasons in a year. We have 1 season a year. It's called hot and hotter. Okay? Or wet and wetter. Okay, 2 seasons then. But the point is, it's very difficult to wear compression stockings for a few reasons. It's very hot in Singapore. Number 2, especially for the men, I have a hard time trying to persuade them to wear stockings, because they're like, really? How am I going to wear my shorts and go out and drink coffee with my friends in slippers? People will give me these weird looks. Women are a bit more receptive because, they have used stockings before. The third thing, of course, is stockings are difficult to put on, because they are not your simple, easy, daily stockings that a lot of women use, but they're very tight, so there's a struggle. And this disease happens a lot in older patients. It's very difficult for older patients to bend down and try and put stockings on. Of course, we've got all sorts of devices, we've got bags, we've got all sorts of sliding devices take on and off. But what the long and short of it is, stockings, first is compliance. So getting patients to put it on is difficult. The second thing about stockings is that it never cures the problem, because the moment you remove the stockings, everything comes back again. It is basically to control the symptoms. Now, there are some patients who love it and work very well. And those are patients who are generally surgery adverse for whatever reason, be it they don't like surgery or they're high-risk candidates. And patients who want a trial of stockings first. Essentially, they say, we want to see whether stockings work, then maybe we think about doing an operation. Okay, so now I've made surgery look like it's a big monster, but we'll show you what it is nowadays. Okay, so that's conservative management of varicose veins. But the reality is the problem will not go away until you do something about the physical problem. And that's where we talk about modern management here. So there are a lot of ways we treat, as I said. Okay, conservative, exercise, leg elevation, stockings. We don't do this anymore, Una boot. It's very, very leceh. Okay, then in the good old-fashioned days, and this is an operation that's been around for a long time, we strip the vein. So if the vein is causing a problem and not working, then you remove the pathway. You just remove it so that it won't backflow down. Then you're of course wondering, okay, if I remove, what happens to that 25% of the vein flow that is responsible for? Well, the long and short answer is it's channeled into the deep veins. Okay, the deep veins will take over the drainage somehow. Okay, and it does happen. So, and the vein, the other question I get is, but isn't the vein useful? Should I keep it for my heart bypass? The answer is, I hope number 1, you don't have to have a heart bypass. But number 2, if the vein is diseased, no surgeon will ever use that vein. It's poor quality vein. Okay? So long and short, you can afford to lose that vein. The question is how to lose it in an effective manner that's less painful. So surgical stripping, as the name implies, involves stripping the vein. Usually patients get an open wound. It's a groin scar, and then they get a whole vein stripped down the leg. And that I don't like to do because it is painful for patients post-operatively, They sometimes have difficulty with thigh pain for up to 2-3 weeks after the operation. Sometimes you have nerves very close to the vein, and then when you strip it, you also strip the nerve. Then you get chronic pain. Okay, so not something I recommend. Nowadays, though, we have moved forward, and now we talk about, okay, don't strip the vein. The alternative is actually, why don't we close the vein from the inside? Okay, which is basically ablating the vein. Since we strip it to remove the vein, why don't we just cause the vein to close off, like block the highway, so that blood doesn't flow down anymore, or doesn't have the opportunity to pool in the legs. Okay, and you can do different things. One is thermal ablation, or heating it, to put it very fancily. Okay, and you can use radio frequency, which is basically a fancy term for microwave. And then the other one is laser ablation. I'm sure all of you have heard about laser. You know, everything that advertisements talk about laser, but that's really very old technology, and I've not done a laser for more than 8-9 years already. Then there's non-thermal and non-tumescence, fancy word, but basically you try not to heat the vein, because anything you heat may be associated tissue injury around the vein. And then now, lately, we have got a method where essentially you inject glue, and we'll go through them. Now, this is open operation, high ligation and stripping. You can see a scar, okay? And basically you remove varicose vein by removing the source of it, the whole vein, okay? 100 over years, but you need general anesthesia because it is painful, okay? I've done stripping under local anesthesia, and I had to give a lot of oral anesthesia, like, oh, don't worry, it won't be pain, you know, in very sick patients, you know, but it's very difficult, and recovery is slow. Now we do minimally invasive, where we put puncture holes and catheters, and this is what I mean. So this is a slide that shows thermal ablation, where we heat the vein, and a very simple protocol under ultrasound, and this is done with the patient awake. We are talking to the patient. It's done under local anesthesia. We just give a little puncture, and this is the vein, and what we do is we make a small puncture in the vein. This is done sometimes in a small procedure room as a day surgery case, and we introduce essentially a fiber or a device, and this is a heating catheter, a heater probe, okay, inside the vein. And what it does is you heat the vein to cause the proteins in the vein wall to break down, and then it becomes, basically the vein will shrink, okay, and over time, after it shrunk, it becomes scar tissue, and then the body absorbs it. Now, laser was the old way we used to do it. It's not a bad way of doing it, but understand that laser is very high temperature. You're running it at 1,000 degrees. And we normally, during this heating process, we give fluid around the vein to protect the surrounding tissue. We give a layer of fluid, we inject around the vein, so like a heat sink. But with laser, you can sometimes cause surrounding tissue damage. And generally, patients with lasers done for the varicose vein tend to feel more pain than if we were to use a slightly better heater probe called radio frequency, which only heats up the vein to 120 degrees. And they have basically looked at using heater probes instead of laser, and you can see that after you treat it, at 5 years, 90% of patients still have their veins closed and permanently closed. Okay? Everything in surgery we look at 5 years, because we assume after 5 years patients won't come and see us again. But having said that, what it means is the recurrence rate is very low. Only maybe about 10% initial studies will have a problem with the veins again. Okay? And then these are some of the side effects after you heat the vein up. Ecchymosis is fancy word for bruising, redness, surrounding blood clot formation, infection, pain, numbness. As you can see, at 5 years, nobody complains very much for all these. In the first week, at most 5.8% have a little bit of bruising, but most are 1%. So it's a very safe technology, radio frequency. Okay? We looked at our experience, and I've done thousands of these cases, and how we do it is usually we mark the veins to see. You can see these are the big varicosities, okay? But the main problem is not this. This is the physical problem. The main problem is the underlying vein inside, okay? And they're linked to these fancy ones outside here. Then essentially we do an ultrasound and we mark it, and then I do a small injection and put a sheath in, okay? This is done with local anesthetic, okay? Under ultrasound guidance. No radiation, everything under ultrasound guidance, okay? Then we put in a little sheath. A sheath is a tubing that allows us to access the vessel anytime, okay, under ultrasound and under local anesthetic. And then we put the probe up under ultrasound, okay, and we burn it from the junction all the way down. But before we burn it, because we are burning it, we give a solution of local anesthetic around the vein, along the track of the vein. Okay, that means we put it next to it and we surround the vein here with a lot of fluid. This makes it very comfortable for the patient, prevents any heat injury, and also after the operation, patients don't feel anything. And then we just basically start the machine and burn the vein. Okay, at the end of it, we dress it up. All right. Patient goes home on the same day. I encourage them to resume their normal activity. I always tell the story that my best heroic story was this lady who was 65 years old from Indonesia, and we did the vein in the morning. And then in the afternoon, she called me and said, "Doctor, the dressing's a bit loose." I said, "Oh, okay, aren't you at home? Just tighten." She said, "No, I'm actually in Orchard Road shopping, and it's just come a bit loose. Can I just take it off because it's a bit embarrassing when I'm wearing a skirt?" But yes, so the pain score is very low and patients recover very fast, and many actually go on very well to normal activities. I expect that to happen, all right? And then sometimes we put you on stockings for 2 weeks and take some medication if you use a heat-based therapy. Results we looked at in the local patients, essentially very much similar to what has been published. Not very many complications. In fact, at 6 months, most patients have had no problems at all. Some have had a little bit of pain, but most of it is settled. In terms of pain score, you can see all very low, almost. And immediately, in the part that's burned, 3.3 is the highest. In the part where we remove the veins, 4.1 and sometimes 4.5. But at 6 months, not a lot of pain. Recurrence, very little. For the main GSV, 0. For some side branches, you can get a little bit of recurrence, but that can be easily dealt with by another series of injections or just removal. Recovery time back to work, 1 day to normal activity. Some patients, 4.2 days. If you do a little bit more, including injection of the veins and removal of the small veins, it take a little bit longer to get back to work. But most times I give the patients 2 weeks of MC anyway. From old practice and habits, but also because sometimes patients like to take a break from work. And this is a perfect excuse. But don't say I say that. Okay? So it's actually not a bad way to deal with this problem, as far suited. But now, recently, in Singapore, we have brought in something called the venous seal. And this is something that has just been introduced. It's actually ongoing, and it's technology that has been available in the United Kingdom and United States for more than 5 years already. We just got approval to bring in this device, despite me asking for it for a long time. And finally, we brought it in, and I think it is changing. Now, if you thought that radiofrequency was already quite impressive in treating the veins, this you should see. Okay, number one, the problems with radiofrequency or with any heat therapy is you can have this problem, some scarring, some heat-induced injury, some bruising and some inflammation of veins and nerve injury, and you need to wear stockings. Okay? With this, what we are injecting is something called cyanoacrylate or glue. To put it very simply, tissue glue. Now, when this special glue comes in contact with blood or plasma, which is plentiful in the veins, it begins to basically polymerize or harden, okay? And then essentially, it forms a strong, basically a hard block inside the vein that never goes away, okay? Now, this is not something new. We use a lot of this for treating other parts of the body, and we inject a lot in the brain. This is for patients who have got brain bleeding veins in the brain or bleeding arteries in the vein. Sometimes we inject this glue inside to plug the hole and stop the bleeding to prevent strokes. So if you can use it in the brain, theoretically you should be able to use it anywhere else in the body. So somebody thought about it, okay? But the key thing is you eliminate the need for a lot of pain and bruising from the heat therapy, nerve injury, no need to wear stockings after this, okay? And the features of this is basically this device, all right? And what it does is essentially, I'm just going to go through this quite quickly. You can turn off, but what you do is we do the same thing. We sort of basically make a puncture in the vein, and we put this tubing up under a wire. And this is all done under ultrasound guidance, okay? So very, very clear. There's no error about injecting the glue to the wrong place into the deep vein. No, it's all under ultrasound, okay? And under ultrasound, you see, very nicely, then we just shoot glue in there. So you're not heating the vein at all. You're just shooting glue into the vein, and you compress the vein. with your hand and with the ultrasound probe. And then basically, for 3 minutes we press, and then we shoot more glue along the, so basically along the whole length of the vein, we just shoot glue or inject glue inside, okay? And it seals the vein very nicely. So instead of burning it, we block it off with glue. It's a very elegant process. And then when you're done, we just pull out this little tubing, and the hole is that small with a little bit of plaster. Okay? I can't show you the actual procedure in a video because we are not allowed to by government regulations. But what I can show you is some photos, okay? Same thing. We use this device that's just me folding my hands, and this is what the glue looks like under ultrasound. Okay? Essentially, that's what we do. Now, how good is this? It first started in 2011. They looked at the first 38 patients and followed up for 3 years. And the primary endpoint was just how safe it was and how efficacious. And then they went on to other studies where they enrolled more and more patients. And essentially, they looked at several endpoints. First, they compared it with the heat therapy, radiofrequency, which is still available as a treatment. And then they want to look at how it reduced post-procedural pain and bruising, okay, essentially. And then if you look at it, the first one where they enrolled 38 patients, at 3 years, 92% of the veins were closed completely with no reopening, okay? And in the European studies, the numbers were a bit higher, but also again about 93%. Then the US one, which is important because the US trials are very rigorous for approval. You know, in the United States, the market is very huge for this treatment. And any device that goes to market must be very good. And it must run it in very big trials and big clinical studies for safety reasons as required by the FDA. And this one, they actually compared this, and they basically took one group of patients, assigned half of them to this glue system and half of them to the radiofrequency treatment, which is the older treatment, and they compared the outcomes, and they found that it was very good and comparable in terms of closing the veins, but they essentially had less problems with bruising, pain, and they didn't need to wear stockings. So essentially, this is what many of us are switching to now because it is very efficient, it is painless in the procedure except for the initial puncture where we give local anesthetic, and we've got very, very good outcomes in terms of less post-operative bruising. You can actually walk straight after the procedure. You don't need to wear compression stockings as you would have to if you did radiofrequency or laser. Okay. Now, begs the question then, what do we do? Now we have treated the long main great saphenous vein and short saphenous vein. What do we do to those big bulging veins? So essentially, we remove them or we avulse them. We sometimes give local anesthetic and then we pull them out. This was a video that was shown on TV recently in a program that we talked about veins. Oops. Wait. How do I play this? Wait. There we go. But essentially, we make a very small, tiny hole in the vein. And this again with the patient awake. We're having a discussion with the patient. I usually ask them how their day has been. Do you feel any pain? It looks worse than it actually is, trust me. And we talk, and these are big veins. You can see very big veins. And we basically, essentially just pull them out through very small holes, almost painlessly, with local anesthetic, okay? And the vein just gets removed. So treatment of varicose veins has been significantly improved over the last 5 years. Most cases are done as day surgery now with no need for a stay in hospital. You walk home immediately after the procedure, you return to sports activities in 3 to 4 days, and you can return to work within the same day. Most importantly, it's also cosmetically very pleasing because all these scars usually, unless you are a person who scars badly, heal very well, and you can't really see the scars after that already. An example, this gentleman had huge ones here, okay? Immediate post-op after surgery, 24 hours later, you can see all have been removed. Very small puncture wounds remain. This was a patient I did not too long ago from Myanmar. As you can see, very big, ugly veins. And then 2 weeks later, everything has settled down. So it works very well because it leaves the patient with very minimal morbidity. Thank you very much.